Good evening. So today's class is on CNS infections. I'm not going to speak about anything very great. This is just common things that you will see every day. Let's just discuss those. All the rare things anyway we'll anyway have to read up. So, as all of you would have known or realized over the past few months, CNS infections are the most devastating of all infections if you haven't treated it properly or if you haven't identified it early. So, most CNS infections either enter by crossing the blood-brain barrier or they can go via the transneural route, bypassing the blood-brain barrier. So many times you may have to treat it like a medical emergency because if complications arise, they become irreversible. So what we try to do is look at the basic neuroanatomical approach. We'll divide it as meningitis, encephalitis, focal lesions, and myelitis. I'd like to just concentrate on the common ones. So, what is meningitis? When you have fever, headache, and neck stiffness. When you have fever along with okay, that's when focal lesions or abscesses should be. And then when people present with fever, with multiple cranial nerve palsies, that is when you suspect a skull-based osteomyelitis. So, among the spinal cord infections, you can have a myelitis. It could be an epidural abscess. It could be a disc which is infected and going in. Could be arachnoiditis. Okay, and there are multiple other element syndromes which can present, which we are not going to go into. So, what I would talk about today would be acute meningitis. Among the meningitis, we'll just deal with the common ones, which is pneumococcal and meningococcal. Okay, I've divided into acute and subacute meningitis. What's the most common subacute meningitis we see? TB. And maybe one slide on crypto. And the most common encephalitis, which you see or which you should know, which is HSV. Okay. So, what is meningitis? What happens in meningitis? What is inflamed? Yeah, the covering of the, which is the, which covering is inflamed? Yes, yes, and that inflammation leads to the clinical manifestation, which is what is presents with. Now, look at three case scenarios. Tell me what you think. The first is a 25-year-old man. He presented in the morning to casualty. He has a 4-day history of fever, headache, vomiting, and 2 days he is altered. His GCS is 12 by 15. He is tachycardic, tachypneic, BP is 100 by 70. Thus, neck stiffness and all other systems are normal. What does this look like? It's a person with an acute meningitis. So his total WBC count is like 18,000. Okay, and his CSF showed 24,000 cells with 97 neutrophils. Protein is very high, 931 with a very low glucose. Many pus cells with gram-positive cocci. This is his X-ray and that is the CT. What do you think this is? Probable pneumococcal. What are you seeing on the CT? Just say whatever you feel like. What do the ventricles look like? Yeah, the ventricles look compressed. Then anything else you're seeing on the cortex? Yeah, all the gyral contours are lost. Okay, this is on a plain CT. You don't need to do an MRI to see this. So this is pneumococcal meningitis. These are all our original patients. What was the outcome? You give therapy, they completely improve, provided it started early. Case 2, another 25-year-old person from Virudhampet. Okay, 2-day history of fever, headache, vomiting, some abdominal pain, and 1 day he had a rash. Okay, This neck stiffness, there is a petechial rash all over the body. GCS is normal. You want a better picture of meningococcal meningitis. Okay. So this was the CSF, 1450 cells, 85% neutrophils, and sugars is 5 and protein is high 450. It shows gram negative diplococci. Like you said, this is a meningococcemia with a rash, purpura fulminans. This person actually died. This is not what we will deal with, but this was one of our patients. This is a newborn baby. Okay, admitted 48 hours postpartum with fever, irritability, and grunting. Mild jaundice was there. Total counts was 23,000. CSF was 5,000 cells with a glucose of 8 and a protein of 534. What are your differentials here? CSF has 5,000 cells. Okay, so yeah, what are you saying? HSV. Okay, anything else? It's still neutrophilic. Which bacteria here would you think? Anything more common in this age? Okay, we'll come to it. It actually grew GBS. Okay, group B streptococci, and the child didn't do well, dropped sensorium. Okay, had actually had an epidural empyema and succumbed to the illness. So, what's our approach to meningitis on a practical basis? What do you see in the adult group commonly? That is what you must suspect first. Okay. So, before we go to that, you must remember what you have learned as UGs is that you should look for Koenigs, you should look for Brudzinski's, all that should be positive. But actually, when you look, these are papers which have been done, which actually shows that the sensitivity for these things are very low. Okay, if you actually and the specificity is high, but if it's not there, it doesn't mean that the person doesn't have meningitis. Okay, you have heard of the jolt accentuation test. Namrata likes it. She keeps so you do a horizontal shaking of the head and see whether there is neck stiffness. Okay, so don't rule out meningitis just because you did not get a Brudzinski or Koenigs. Okay, this is the epidemiology of usual meningitis that we see. So this is in the children, okay, the first one, while the second one is in the adults. Okay, so if you see the large population, large group in the children is actually group B streptococcus, which is what our case also had. While in the adults, okay, it is strep and Neisseria, and then it strep actually takes over the majority. It's only in the extremes of age that you will get listeria. Okay, so mainly strep and meningococcal infections. Okay. So strep and meningococcal form 80% of our meningitis, and by far the most frequent bacterium which is isolated will be strep pneumoniae. Okay, or data from large meta-analysis have shown that only 45% of the people will have this classical triad that we keep talking about as UGs. And always remember, post procedure, think of gram negative organisms. Okay, and in tropical countries, always keep TB, milioid in the mind, even when they have an acute presentation. Though it is not the most common thing, so I don't want you to go back thinking 1 week and TB, but you must always keep it in mind because it's India. Okay, so pneumococcal usually presents with high-grade fever, neck stiffness, and vomiting, while meningococcal, always remember the rash. The rash is seen in 64% of patients as per studies, okay, and out of that 64%, 91% will present with petechiae. Okay, and while listeria, they actually present with a brain stem sort of syndrome. It's a rhomboencephalitis-like presentation. So, in a person who's had a procedure, like we said, okay, suspect meningitis if the patient has fever, headache, altered mental status, okay, and the organisms that you must keep in mind, other than the normal ones, are gram negative organisms. What will you look for in the labs? You will do a lumbar puncture. You must do it as soon as possible, okay, and things that you must look out for is it looking turbid? Is the WBC cells more than 1000? Is there a neutrophilic pleocytosis? Is the CSF glucose low? Okay. So this is a table comparing between bacterial, viral, TB, and fungal. Okay. So if it's the normal bacterial, which is what we are talking about now, you have a high opening pressure with a cloudy looking CSF. Okay. With high cell count, which is neutrophilic, and a low plasma glucose with a high protein. How is this different from, let's say, TB? The protein will be very high. Okay. And it's mostly lymphocytic, while the cells will not be that high in a tuberculosis. While viral, you'll have a near normal glucose with lymphocytes, so slight cells, okay, and a mildly elevated protein. Okay, fungal, your opening pressure will be very, very high, okay, maybe cloudy, maybe clear, with a count which is not too high with lymphocytes, and not glucose. Okay, and the protein may not be as elevated as in a TB. So the gram stain, we should, most of the time we send gram stain, but we do not follow it up. So actually, you must follow up all gram stains if they have been done early. Why don't we get positive gram stains? What do you think? Yes, that is the actual problem. It's not the CSF gram stain is very good, and at the same time send blood cultures. Okay, 90% of the time you can actually isolate if it's an untreated patient. 86% in Neisseria, 60% in Haemophilus, and 28% only in Listeria. Okay, so what is our problem? Like you said, it is because it actually should be done pre-treatment. Okay. How many of you sent antigen test on the CSF? It is very, I'm not sure. Maybe depends on where you're working, but it is a good test to send. Okay. Pneumococcal antigen test is available in our lab. It's fast and easy to perform, has a great sensitivity. The best technique to do it is immunochromatogram. Okay, and actually our thing reports it. Those who have sent, you'll see it'll actually say negative for meningococcal, pneumococcal, and Haemophilus. Okay, and it actually beneficial when antibiotic therapy has to be initiated before the LP. So imaging, do you have to do imaging for everyone with meningitis? When do you have to do? Okay, you only do when you suspect papilledema, you think there is papilledema, there is seizures, there is focal deficits, okay, the person's sensorium is low, or in any immunocompromised patients, okay. You do not have to order it as a routine. Okay, unless you suspect one of these, don't do, because you would delay. It's not about doing it, it's about the delay that you would take sending the patient here and there to do a CT scan. So what do you think are the most important causes of delay in appropriate therapy in pyogenic meningitis? Delay in LP, delay in imaging, then third would be an atypical clinical presentation where we actually didn't suspect it in the beginning. Okay, so atypical have to sharpen our clinical skills, but this is something which we can avoid. So first dose must go in as soon as possible. Okay. Do not delay antimicrobial if there is a delay in obtaining CSF or imaging on the Madri. Okay. Prior to administration, just because you administer antimicrobial, your chemistry or cytology is not going to change that much. It's the gram stain which may change. which anyway, I mean, so just because you have given one dose, your protein count is not going to change, or your cells are not going to immediately drop. Okay, so do not delay antimicrobial therapy. What is the empirical therapy that you use? Ceftriaxone and Vanc. Why do you use Vanc? Is it for staff? But now look at our this thing, epidemiology. It's not like it's so much staph meningitis that we are going to see unless the patient is immunocompromised or has a bacteremia. So what is it? Why do you add vancomycin? Yeah. So most countries have actually documented more than resistant pneumococci. That is why you use combination therapy with vancomycin. And once you actually get the MIC, or you realize that it is penicillin susceptible, you can downgrade. Okay, and you can use penicillin or ampicillin. And what we target is a 14-day therapy. So this was a study done looking at the prevalence of resistant pneumococcal pneumococci, which actually showed resistance varying from 53 to about 75% across the countries. What you must remember is that in pneumococcal meningitis, okay, you need a much lower MIC. Okay, so anything more than 2 is actually considered resistant, while in pneumonia it's only more than 8. Okay, so which is why most of the time you do not downgrade, you keep it at ceftriaxone, but you do not have to keep giving manc once you realize that it is susceptible to cef. Okay, so this was actually a Danish study which looked at about 200 people with bacterial meningitis, and it looked at the time given, the delay in giving the antibiotics. And if you look at the last column, when there was a more than 6-hour delay, okay, the adjusted mortality went up by one, it was 1.5, and unfavorable outcome was 1.5 times the other. Okay, so starting early, starting appropriate therapy, very important. While if it's meningococcal meningitis, your management is going to be same, which is why ceftriaxone is a safe drug in everything. It's 2-gram IVBD or cefotaxime, and you can downgrade. The therapy can be actually slightly lesser. Okay, only thing you must remember is that if there is a role for prophylaxis. What is the prophylaxis that you can give in meningococcemia if there is transmission? Correct. Good. Rifampicin you can use, ciproflox, and even ceftriaxone can be used. Rifampicin is an oral drug. You use 600 mg BD for 2 days. Okay, for close contacts, ideally it should be given on day one of the exposure, but there are studies done which says even up to 1 week they actually give, but maximum benefit is in the first 48 hours. That is a household or any close. Actually, if we get exposed, we are supposed to take. We have taken as PGs and all. Next is what about treatment with H influenza meningitis? Again, ceftriaxone can be used. Okay, so it is the treatment. It's similar to meningococcal meningitis. Prophylaxis may be needed to address the nasopharyngeal colonization. Okay, so this is about the most common ones: pneumococcal, meningococcal, H influenza. What about urgent steroid therapy? When do you give it? Yeah, so I've seen that almost all of you write for every patient DEXA. Okay, is that needed in an acute bacterial meningitis? No. The only indications is if the CSF is cloudy, if your cells are more than 1,000, or if you have picked up bacteria on the gram staining. What is the dose you give? It's 0.15 mg per kg Q6H for 4 days. It has to be given before the antibiotic. Okay, so the sister shouldn't just administer off the antibiotic and then give DEXA in the ward. It's no use at all. The DEXA has to go in before the antibiotics. You can discontinue if the culture grows anything other than strep. Most of the time when it doesn't grow, then you sort of continue and finish the 4-day course. If the patient has already received outside, Actually, there's no point in giving that exam.
Practically, only this cloudy CSF we won't know
Before we give, yeah. So the first dose may go in. Beyond that, you have to decide. So this was a meta-analysis done with some 25 studies and 4,000 participants. If you look, we want to just look at it and tell me what you think. What showed maximum benefit? Role of steroids in bacterial meningitis. Maximum benefit is with hearing loss and short-term neurological sequelae. Actually, the overall mortality doesn't show that much benefit, but the short-term neurological sequelae, I mean side effects, will be prevented. This is according to this meta-analysis. Did you guys get that, everyone? Yeah, because overall mortality, it is crossing the confidence interval. Yeah.
This is due to the toxin of the bacteria, or what are we trying to?
We are multiple things. We are, yeah, mainly the inflammation. Okay. After all this, even if you are given appropriate full therapy, the mortality with pyogenic meningitis remains high. Okay, if you see that this is strep pneumoniae, this is the other things, meningococcal. Okay, so that all the more reason why you must be more aggressive and start therapy early. And the increased inflammation is what we attribute this mortality to. Vaccines, I'm not going to go into this, but you know that there are vaccines. Okay, pneumococcal polysaccharide and protein conjugate vaccine is available. So all people with who are elderly, multiple comorbidities, immunocompromised, better to advise vaccines. Okay, other people you must advise vaccine is pneumococcal, people with asplenia. Yeah. So finally, the management algorithm would be that if you suspect bacterial meningitis, okay, take blood culture scat, okay. If there is a clinical, actually proper clinical presentation of a meningitis, then it is pretty straightforward. So you actually take blood culture and start empirical antimicrobial therapy plus minus DEXA. While if it is not so clear is when the LP comes in, and then you have to do the LP and look at the CSF findings and then decide. Then it would be either a definitive therapy or you continue an empirical antimicrobial therapy. This algorithm is up to date. Okay, subacute meningitis. What's our prototype? TB. Okay, tell me what you think. This is a 41-year-old man, seropositive, low-grade fever, headache, 2 weeks with neck stiffness, some nodular skin lesions are there. CSF shows 70 cells, lymphocytic protein is 133 with a sugar of 42. The skin lesion is showing granulomatous inflammation. TB. This is our patient actually, but both the CSF and skin biopsies came as cryptococcus. Okay, and his FAG was positive, and he was actually treated with ampho and flucytosine and became better. So keep in mind cryptococcal, but still the prototype is TB. Okay. Now, just before I'm not going to go into detail on cryptococcus. Meningitis is the most common manifestation of cryptococcus. Why is it not cryptococcal pneumonia or some abdominal thing? How does pneumococcal get phagocytosed? It's mainly through a complement activation pathway, right? So CSF does not have complement clearance, is very low. So all these things escape and go and sit there, and that's why there is a streptococcal meningitis, which is its most common manifestation. I mean, it goes there and manifests. And why is it that this, that the ICP is very raised, no, in cryptococcal meningitis, CSF just gushes out. And why is that? other than on top of all the common?
Basically, the predominance of like it's also based on so the cisterns are blocked completely.
Okay. There's inflammation, all those normal things. Are there anything else? Apparently, it's supposed to produce a mannitol like substance, and that sort of draws the fluid into the thing, increasing the pressure. Okay, I'm not going into cryptococcus, but just in mind when you have a subacute meningitis. Okay, this is a 33-year-old man, low grade fever, headache 2 months, HIV is negative. He has neck stiffness, left sided facial palsy, and left hemiparesis. 280 cells, glucose is 13, 2.4 gram protein, and his CSF expert came positive. Okay. So, what is the normal clinical features in TB meningitis? This is the most important thing for you to remember is that the first 2 weeks or 3 weeks, if they come to you, they actually may not have fever or severe headache or neck stiffness. Like if you think of all the TBM patients that you have treated, okay, who have come within 2 to 3 weeks of presentation, they will present like this. None of them will have that florid meningitic picture. So it is very easy to miss. They just present with non-specific syndrome, okay, and that evolves into a subacute meningitis. Beyond 3 weeks, only they start developing all these focal neurological deficits, cranial nerve palsies, most commonly the sixth one, which you know why. Okay, third, then seventh. Okay, about 10% of them can present with hemiparesis. And the CSF is typically about 150 to 1000 cells, lymphocytic, with an elevated protein and a plasma glucose, which is usually less than, ratio is usually less than 0.5. Okay, so this prodrome, remember the prodrome last 2 to 3 weeks is just lassitude and low grade fever, and then only that meningitic phase comes in. So if you want to pick up your patients early, when patients come to you with significant constitutional symptoms and just tiredness, suspect in the right subset of patients. So this, I mean, you guys know the basics of TB meningitis. But I'll show you something which you may not have seen. We have looked at this is the CSF changes in TB meningitis over the months, days to months. Okay, tell me what you think from this. Look at that glucose graph. Okay, or before that, look at the counts graph. So if you take CSF from a patient, I mean, do a test on day one, and then you decide to repeat after 5 days and look at the counts again, what will happen? Yeah, so you'll think that everything has gone up, and like you're not treating properly. So what is the take home point? You should not repeat immediately. Yeah, if you're repeating, you should be repeating after a while, or you needn't repeat if you're sure of your diagnosis. Okay, or if only problem you need to repeat. Okay, so actually you look at this is the cell thing, it actually goes up. You can see it goes up and then comes down. Okay, so if you have gone and done the repeat CSF at this point, you will pick up an increase in cells. Okay, so same thing. I mean, the other thing is that with glucose, if you see, it remains low for quite a long time. This is the 60-day. Beyond that, only it starts going up. So CSF glucose takes a long time to normalize. Okay, I think most of you know the MRC TBM grading. Okay, just to revise. Okay, in grade 1 there is no focal neurological deficit. Okay, you sort of pick up 15 patients. 15% of patients you pick up at this point. Grade 2 is when the GCS is between 11 to 14. Okay, 30% of patients fall here, while grade 3 is GCS, the score is less than 10, and 50% of them will have full deficits. The other important risk factors are HIV infections and MDR TB. Okay. What does MRC stand for? Yeah, British Medical Research Council. Okay, so we'll do a diagnosis on the microbiology is by Zeal-Nielsen staining. Okay, 10 to 20% of the time only it's picked up, which is why no, when you don't pick up, you can actually repeat a large volume CSF. Okay, and re-examine and see. Expert is something which is fully endorsed by WHO, 60% sensitive, but fully specific. So it's rather a rule in rather than a rule out test. Okay, now you know that there is ultra, but ultra you will have to always take it with a pinch of salt because lot of times it comes positive. So in the correct clinical scenario, yes, but everyone with ultra positive you do not treat. What about radiological diagnosis? What do you look at? So this is something for you to know. There is actually a pre-contrast hypersensitivity density in the basal cisterns. Okay, so if you have hydrocephalus along with this basal enhancement and infarction, okay, that sort of almost tells you 95 to 100% that this has to be TB. Can you look at this? In the basal cisterns, can you look at this to see? Actually, in other things also. Okay, this hyperdensity actually, if you see, this can be seen on the CT. What else are you picking up here? Can you see, just describe the CT? This is a non-contrast, okay, but it's picked up some hyperdensities. Then the ventricles are dilated. Do you agree? Anything else? Can you see some periventricular lucencies? Those periventricular lucencies also actually tells you it's suggestive of TBM. Okay, so non-contrast basal hyperdensities, dilated ventricles, and actually periventricular lucencies.
Where is the basal?
This yeah, and the periventricular lucencies are this which you see around the ventricles. What about this? This is a much more worse CT. What are you seeing? Yeah, there's mass effect, the cerebral edema. Here it's gotten obstructed. Okay, it's become like a trapped ventricle. Okay, all this is on CT. We're not even doing the MRI. What an MRI will help extra is if there is tuberculoma, especially if there is when you do a GADO enhance, you'll see actually on the leptomeningeal you may see small tuberculoma sitting there. DWI if you do, you may see small ischemia, early infarcts, arthritis on MRI. Those MRI will pick up for you, but CT itself will tell you lots. Okay, anti-TB therapy is 2 months plus 10 months, at least 1 year. Okay, remember that. Do you think ethambutol is a good drug in TBM? No, okay, actually ethambutol penetration is not great. We give it because it's a combined therapy that we give. Okay, the core antimicrobial agents in TBM is isoniazid, rifampicin and pyrazinamide. All of them enter the CSF, okay, especially when there is meningeal inflammation. It sort of increases your penetration and everything goes in. Ethambutol is actually less effective in meningeal disease. Okay. So what is the inflammation directed therapy you do in TBM? Steroids. What is the dose we give? Yeah. Okay, so you start at 0.4 mg per kg IV and then you decrease it weekly, then 4-3. There are a lot of studies done showing giving a prolonged course may be better. Okay, there are other studies which are shown like use when there are large tuberculomas not improving, use of other agents like infliximab, etc. But we will not go into that. For the basic thing, you must remember that the main inflammation directed therapy is steroid. A lot of trials have been done and shown that steroid has reduced mortality. The risk ratio of 0.83, that means a 17% reduction in the mortality. Okay. Okay. Just one slide. Okay. Neuromyelioid. again presents with a brainstem sort of syndrome. Okay, when people with uncontrolled diabetes, immunocompromised patients present to you with a subacute or maybe even an acute meningitis, okay, and your MRI showing brainstem lesions, and clinically you have found cranial nerve palsy, suspect neuromyelioid. So this person, what are you seeing here? There's something in the pons, there's something in the middle cerebellar peduncle, okay, here, okay, here is the middle cerebellar peduncle pons. So always suspect neuro have a brainstem syndrome in the correct sort of patient. Okay. I'm not going to go into that. It was just to tell you that this is a possibility. Okay. What encephalitis would you like to discuss? HSV. Okay. When do you suspect an encephalitis? When there is a fever along with altered behavior, new onset seizures or focal deficits. Okay. Always rule out other causes. I'm not going to go into that. Metabolic, toxic, autoimmune. Okay. And now remember that if there is fever, but there is a lot of movement disorder sort of thing, intractable seizures, okay, dystonias, then you must suspect autoimmune encephalitis. Okay. Everything, don't put it into one HSV. So to call it encephalitis, you must have encephalopathy, okay, and evidence of CNS inflammation, which will be demonstrated by fever, seizures, or focal deficits, along with the CSF pleocytosis, which can be just more than 4 cells. That's enough. In a person who you're not getting a seizure, but you think there is subacute, EEG finding of encephalitis is enough, or a neuroimaging, which is suggestive of encephalitis. So what is the evaluation you do? CSF, very less cells will be there, but some cells will be there. Okay, predominantly lymphocytic with a near normal glucose and a mildly elevated protein. Make sure you do HIV testing. Encephalitis, you may have to do MRI if you want to really prove, and radiological imaging is better MRI for an encephalitis. Okay, and HSV multiplex PCR, which you do. Mainly you're looking for HSV 1 and 2. So, will you get RBCs in a CSF with encephalitis? CSF RBCs. Anything about the RBCs and the CSF you must remember in a patient with encephalitis? No, if your tap has been non-traumatic, but you have got RBCs in your CSF, is probably a HSV encephalitis. Okay. So the most important diagnostic is HSV encephalitis, because if there's a delay in treatment, it can impact morbidity and mortality. Okay. So I'm not going, it's the same thing. Fever will be there 90%, focal deficits and altered mentation. It is sporadic, it can be fatal, it can involve any age group. Okay. So typically lymphocytic predominant, okay, and HSV PCR has a very high sensitivity, 98%, and specificity is also good. Okay. It's because of this inflammation of the temporal lobes that you see the erythrocytes in the CSF. So what are you looking for here? Can you look at those? What are the long white arrows? That's not exactly the temporal lobe. It's the insular, okay, both the insulae, okay. There are some signal intensity changes over there. Okay, what about the black arrows? That's the mesial temporal lobe. Okay, that also there is some hyper intensity there. What about the short white arrow here? What is that? If you can see, there is a no. What is that? There's an uncal herniation which is starting. Okay. Yeah. So these are all things to look out for. Okay, insular cortex, how does it look? Medial temporal lobe. Okay, is there a uncal herniation? And if it's clearly there and it's a very florid HSV, then you will see a lot of temporal lobe abnormalities. So early treatment, better outcome. Acyclovir, how long do you give? How much do you give? 10 mg per kg IV. 8 hourly, 21 days actually. What are things to look out for when you give acyclovir other than renal failure? Yeah, correct. Okay. So these are other viruses that you must know, which I'm not going to go into. Other than HSV, you must think of chikungunya, okay, dengue, Japanese encephalitis, West Nile, okay, rabies, other things like scrub. All these things can present with an encephalitis-like presentation. Okay. What do you think this is? Cute encephalitis-like presentation. 32-year-old lady, fever for 1 week, duration of yeah, falciparum malaria. Okay, don't forget these ones. Okay, focal brain syndrome. Usual causes are staph, strep, anaerobes. Okay, do not chuma give empirical therapy. Treat as per the culture and sensitivity. The main management, if you have a focal lesion or a brain abscess, is twofold. One, surgical drainage and appropriate antibiotic therapy. Okay, the duration of therapy will be long, will be about 8 weeks on a average, and basically you stop when that thing is completely resolved. Yeah, ideally, yes, you need, especially, I mean, if there is a collection and neurosurgery has removed it, then okay. If you have not and you're keeping on follow up, ideally needs.
6 weeks and still if it's not been drained, we do 6 weeks. Many times
you will have to drain because
many
if
times in brain absorption they'll say complex to drain near brain stem, all of that. So we will not drain them. And clinically they'll become very good after 1-2 weeks of therapy. We'll still continue for 6
you will have to continue and monitor.
And then after 6 weeks, we'll just monitor on clinically and you'll have to do radiology some.
I'm not sure what you do because many times we are caught up in these circumstances where you're neither able to drain or it's not getting fully resolved by itself. But ideally, we'll need a prolonged antibiotic course. Then sometimes we bravely stop, like we have done many times, and patient has actually done okay. But if it goes the other way, then I mean it will become disastrous. So better is to give a prolonged antibiotic course. Okay, what is this? Another patient, male with headache and fever for 10 days, tonic-clonic seizures over 24 hours. Ring enhancing lesion, no history of TB, HIV negative. Huh? Yes. Oh. Neurocystic psychosis. Remember the neurocystic, I'm not going to go, you know neurocystic psychosis, we have had multiple talks on this, but it's another common, it can be a presentation with an acute altered sensorium.
Why fever though?
Normally chronic NCC, okay, these are all actually real patients. This person actually presented with fever. If it's a chronic NCC, they just present with seizures and nothing else. Only thing to remember in NCC is that you will not directly start albendazole. Okay, you will only give anti-edema, anti-seizure medications. Anti-edema is not needed if there is no edema, if it's an old thing. Okay, but only anti-seizure medications and then only albendazole. Steroids is if there is significant edema around it. If there is no edema, it is just neurocystic psychosis sitting there with nothing else, you actually don't have to give immediately.
So when do we start albendazole?
According to up to date, it says you can wait 48 hours later and start. But what our neurology does is they call back at review, even 2 weeks down the line, and only start. There is no urgency at all to start albendazole. Just start anti-seizure medications and anti-edema.
So if you don't have edema around the ring enhancing vision, you need to give DEXA also before albendazole. Just see anti-seizure and
anti-seizure alone, and later on albendazole. Recently, we had a patient who had multiple lesions, whom we thought we would start albendazole a few days later, but that neurology said no. They said wait for 3 weeks later and then you can start. There is no urgency. Okay, what do you think this is? Someone who presented with an acute flaccid myelitis had fever prior to it. Can be many things. Name some. What are you seeing there? Yes, the SCOD hyperintensity actually seems to be little long segment. Oh, yeah. Fever with an LETM. What is it? What can it be? There is no one diagnosis. Yes, very good. COVID. Actually, this patient had COVID-19 under our neuro. Anybody else? Anything else? Chikungunya can cause, scrub can cause. Oh, okay. See, ADM is just demyelination post this thing. That ADM is considered as a post-virus demyelination. It is not it does not come under the acute infective cause. It's a post-viral thing. But yes, okay. Okay. Polio. Multiple sclerosis is in the brain, multiple areas. This is the cord is also involved. Okay, so differentials here would be COVID-19 can cause polio. Okay, then scrub can cause, what do you say? Campylobacter jejuni can present post, after that can present with a GBS like presentation. This has things in the brainstem. Okay, you can see there's one thing lighting up in the pons and all that. Okay, so have differentials for this in mind. Can rabies present like this? It's mainly a correct rhomboencephalitis, but can present, okay, like an acute flaccid paralysis, but will have lot of other manifestations. So rabies also is possible. Okay, so finally, I'm stopping here. Remember causes of acute meningitis, common things that you see, have a basic neuroanatomical approach. Okay, decide whether it's focal, whether it's global, and whether there is a myelitis component. Okay, last question. What is this? CSF showing gram positive diplo. Okay. Gram negative diplococci? Okay. You're seeing it, no? Kidney shaped stuff here. Yeah. What are gram negative coccobacilli in the CSF? Gram negative coccobacillus. Yes, Haemophilus. And gram positive rods and coccobacillus? Listed. Okay. Thank you. It's all mainly from Harrison and up to date. And I got some, all these cases are from neuro and ID. Any doubts, quick questions? See, normally you do not have to do. If patient has clinically responded, leave it. Only when you suspect other things, treatment is not going the right way, patient is worsening, then you do. If it's TBM, don't repeat early. One place where you would want to do a response trap would be, yes, cryptococcal. Okay, there at the end of 2 weeks, you actually do cryptococcal. In fact, in the therapy of cryptococcal, at the end of 2 weeks, once you prove that it's culture negative, then it's calculated 6 to 8 weeks from there, the fluconazole continuation phase. Normally, normal meningitis responding well, not needed.
John, the guidelines actually say for gram negative meningitis, even 3 weeks of antibiotics is indicated. Normally, just 2 weeks.
I have not gone into gram-negative meningitis, but I think you would have to at least 2 weeks. Most of the time, when you have a gram-negative meningitis, you have another source somewhere else. So that would need source control. If it's a bacteria, anyway, 2 weeks you have to give, plus extra.
Meriam, do we ever have to do an imaging follow-up, like MRI? Because there was one gentleman who came to casualty, one young boy who had a TBM and a tuberculosis. I'm not sure for what reason they have redone an imaging 2-3 weeks into therapy. So that actually showed TB, the meningitis part is getting better, but tuberculosis had increased a little bit in size.
I don't think you have to repeat at 2 to 3 weeks. If at all you're doing at the end of 2 to 3 months, if the patient has not clinically responded, has recruited new symptoms, yes. But at the end of 2 to 3 weeks, anyway, there'll be an increase in inflammation. It will look more, yeah. Yeah.
And despite giving steroids, that the tuberculoma, that penetration.
Initially, in the first 2 weeks, you cannot go by the repeat imaging, yeah.
Only clinical.
Yeah, it has to be clinical. Unless patient has dropped sensorium, there is a hydrocephalus which has developed this obstructive, then you have, but that a plain CT is enough to pick up, no, and do a shunting as necessary.
Then,
I can check and tell you whether you, I mean, as per guidelines, whether you have to repeat.
pneumococcus, do we have to do this rhinorrhea protocol in CSF to look for in a young patient? Otherwise, you don't suspect.
Normal pneumococcal meningitis, no, we don't do. You're saying that this CSF, no, not normally.
Historically, they don't have.
See, any of this can be through the cribiform
Even
plate.
without
With the
patient, so
well, no, yeah, I mean, can be so because even COVID and all, which is going, it's all through the transcribiform. Is one mechanism which has been described. We're not doing that protocol for everybody.
So in an otherwise young person, you don't really have to do
No.
anything to look for a
No,
source
no,
of,
no.
infection for pneumococcal meningitis. About generally it takes 2 weeks.
2 weeks. As per actually up to date, this thing all is only 7 to 10 days. Meningococcal. Okay, I can get back to you on that imaging. Sure. I stopped on time.